Hello, and thank you for joining me today for this topic. I want to first thank GE and Medtronic for sponsoring this program and providing support. It's an honor to be a part of the Elevate webinar series, and I look forward to interacting with you at the end of the program. Today we're going to talk about cerebral oximetry for orthopedic surgery patients undergoing shoulder procedures in the beach chair position. This is a very interesting topic to talk about because of the dynamic physiologic response to the beach chair positioning and how it prevents a very difficult clinical dilemma for anesthesiologists. Then we'll discuss how monitoring cerebral oximetry can be of assistance in these cases. Here's an overview of my objectives for this program. First, we'll discuss the rationale, challenges, and risks associated with managing cerebral perfusion during shoulder surgery in the beach chair position. In particular, I want to address the cerebral perfusion-related risks that are inherent in these procedures. There is a small but not insignificant incidence of hypoperfusion-related negative outcomes in this patient group that has prompted those who are involved with these procedures to innovate ways to preempt this problem. Later, we'll discuss the possible etiologies of this problem and what can be done about it. Secondly, we'll discuss NIRS, near-infrared spectroscopy technology, what the value means, and how to interpret it. And lastly, we'll highlight clinical applications of NIRS monitoring in beach chair shoulder surgery that allows us to balance cerebral perfusion with decreased bleeding in the surgical field. We'll talk about what cerebral oximetry measures, what the typical values are, and possible interventions, and then we'll give some clinical examples of NIRS monitoring. So let's start by talking about beach chair surgery and the clinical problem it presents and how it's important to balance adequate cerebral perfusion with the risk of bleeding in the surgical field in the beach chair position. So first, who are the patients that are undergoing this surgery and why is it important? Well, it's important because it gives us a profile of who are the typical patients and what kind of risks they might encounter based upon their age and medical profile. It's not the same profile that you might see for all comers who are presenting for orthopedic surgery, who really tend to be at the extremes of age, either the elderly who have degenerative joint and bone diseases, or the other extreme, the very young who are typically healthy patients who are involved in sports injuries or accidents. For shoulder surgery, the most common patients, as you can see, are middle-aged, where they represent 17.1 per 10,000 people in the United States who are having this surgery. They're frequently healthy, active patients, and the most common diagnosis here is rotator cuff repair arthroscopy. Second most common is elderly patients, who we talked about. These patients have a unique set of risks due to their comorbidities that are common in elderly patients over 65. And last are young patients, who are the least common, who undergo shoulder surgery in the beach chair position, and these are frequently patients who have sports-related injuries. So there's three different physiologic rationales for what I mentioned earlier, where there's adverse cerebral events that are encountered in beach chair shoulder surgery. First, there are likely patients who are genetically at risk for brain ischemia due to abnormal or aberrant cerebral circulation. We know there are patients who do not have an intact circle of Willis in their cerebral vasculature that leads to a higher incidence of cerebral ischemia in settings where the cerebral vasculature is manipulated. These are typically asymptomatic patients who would otherwise never know that they actually have an anatomic variation until they undergo this procedure and have an unfortunate complication. This is possibly why there's an incidence of this devastating neurologic outcomes in what we would consider otherwise relatively healthy patients undergoing what would be considered routine, uncomplicated procedures. And we've all probably heard of a young, healthy patient who just simply doesn't wake up after shoulder surgery. Second, There's acquired risk factors. This usually impacts the more elderly group of patients undergoing beach chair surgery due to their pre-existing comorbidities, such as hypertension, cardiovascular disease, or in patients who must suspend their chronic anticoagulation, leading to the risk of thromboembolism. And then third, there's a risk of physiologic perturbation due to the positioning itself. And this is really related to the change in hydrostatic gradient and the impact of monitoring blood pressure. This is sometimes minimized or really not even recognized when these patients are undergoing shoulder surgery. So here's a schematic that shows the impact of positioning and the resultant hydrostatic gradient that impacts the site of blood pressure monitoring. In particular, this schematic demonstrates the significant effect that the degree of position influences the mean arterial pressure at different levels and at different blood pressure monitoring locations. It's not unusual at all to monitor blood pressure at a location that's different than the typical location, which is the brachial artery in the upper arm. In these patients, that's not atypical because frequently one arm, one shoulder is in the surgical field. So if you look at this picture to the left, you can see that at a 45-degree angle and a mean arterial blood pressure of 70 at the level of the brachial artery, the mean arterial pressure, when accounting for the hydrostatic gradient, the mean arterial pressure at the top of the cerebral cortex would only be 42, and this is using the adjustment for hydrostatic gradient, where for every 1.25 centimeters, the gradient changes by 1 millimeter of mercury. Now, it's not unusual to actually monitor blood pressure at the calf in these patients because of the fact that there's only one arm available for both blood pressure monitoring and the IV. So if you measure at the calf and even allow for a very liberal mean arterial blood pressure, like in this case, mean arterial blood pressure of 90, this would even be considered too high for most orthopedic surgeons. This still results in a relative hypotension at the level of the brain. Now, if you look at the picture to the right, you can see how these differences are even more pronounced when you change the angle from 45 degrees to 70 degrees in an upright position. Based on the same calculation for hydrostatic gradients, you can see an even more dramatic change where here the mean arterial pressure at the superior cerebral cortex is only 32 millimeters of mercury. So given all these associated risks with this procedure and the patient population, why do we even choose to do do surgery in the beach chair position? It's really completely surgical reasons, and this includes both better anatomical positioning, easier access to the shoulder joint space, decreased blood loss due to the positioning itself, and decreased brachial plexus injury. So why then do we induce hypotension in these patients? This is very common for surgeons to request relative hypotension to reduce bleeding that can impair visualization of the surgical field. Whether this is arthroscopic or even open surgery, visualization can still be impaired with a high mean arterial pressure. And other than induced hypotension, there's really a limited number of ways to improve visualization due to bleeding. Some of these would include hemostatic control of bleeding blood vessels. You can avoid turbulence in fluid used to fill the joint space by reducing leaking from access porticles. There's a Bernoulli effect that causes a change in visualization in the field. We can do regional anesthesia that reduces anesthetic agents. We can improve use of electrocautery. We can put epinephrine in the irrigation fluid for direct vasoconstriction of blood vessels. We can either increase pressure or flow in irrigating fluid pumps to dampen the effluence of blood that obscures visualization in the surgical field. Or really the only choice that we're left with is controlled hypotensive anesthesia, typically with a systolic blood pressure below 100 or even in some cases below 90. So if you put together some of the risks of the patient population and the effects of positioning, you get a sense of some of the challenges of surgery in the beach chair position. These challenges are typically additive, so multiple factors must be considered for each patient. So if you look at these factors kind of individually, starting at the top right and looking at cardiovascular risks, the first is when we sit a patient up, we get venous pooling in the lower extremities, and decreased venous return, decreased cardiac output leads to decreased flow to the brain. General anesthesia causes vasodilatation, and that can worsen blood pressure in these patients who may be susceptible to changes in blood pressure. Hyperventilation with mechanical ventilation at the onset of general anesthesia can result in cerebral vasoconstriction that can lead to decreased perfusion in the brain. In terms of perfusion risks, general anesthesia blunts systemic vascular resistance compensation, so the blood pressure overall is lower. We also shift the lower limits of brain autoregulation under anesthesia, and we'll talk about that in a little more detail later. Third, the target blood pressure in these patients is typically lower because induced hypotension is frequently requested. We don't really have good evidence-based guidelines on what's a safe and reasonable blood pressure to use for these patients. So that often leads to disagreement on what the lowest allowable blood pressure should be for these patients. There's also increasing amounts of published evidence that our old blood pressure targets, where we used to say the brain auto-regulates to a mean arterial blood pressure of 50 and above, that these targets may actually be too low. And what we know now is that that's possibly and most likely too low for good organ perfusion for most patients, particularly those with comorbidities. In addition, neck positioning. These patients require a very specific type of head positioning device that can result in vascular obstruction leading to brain hypoperfusion. We already talked about monitoring of accurate blood pressure. You must adjust for the hydrostatic gradient in these patients. Frequently, a blood pressure cuff is placed on the leg to avoid interfering with an IV, and also the risk of induced hypotension, as we discussed. These are all challenges of surgery in the beach chair position that we need to overcome. So given what we see in patients undergoing beach chair position surgery, are these changes in blood pressure deleterious to the brain? And is there a way to determine what level of induced hypotension is acceptable? Well, here's a study that looked at the effects of beach chair positioning with induced hypotension on cerebral oxygen saturation using NIRS monitoring at various event intervals. This graph shows here the regional saturation on this axis in brain tissue versus time across the bottom axis here. The first measurement here is at 5 minutes after induction of anesthesia, and you see a normal baseline cerebral saturation of 74%. The next here at time point 2 is 5 minutes after changing to the beach chair position. Then time 3 is 5 minutes after induced hypotension, and what you see is approximately a 10% average drop in cerebral saturation. In this study, they determined that 20% dropped from baseline to define clinical significance, and this occurred in 7% of patients who enrolled in the study. And we know from other studies of cerebral oximetry that a 20% drop has been associated with poor outcomes in patients undergoing different procedures. So if you take a look at the overall literature to talk about perfusion-related complications for these patients undergoing shoulder surgery, how often do they occur? Well, thankfully, these events are still very, very rare. So frank stroke or spinal cord ischemia or visual loss are still very uncommon. There is also a small but significant incidence of neurocognitive or neurobehavioral deficits. This number is small, but they're not zero, and they're certainly higher in patients that are undergoing other routine procedures that are not done in this position. Further, there's a higher incidence of postoperative nausea and vomiting in these patients than others, and it's postulated that occult brain ischemia, particularly to the areas of the brain that are involved with nausea and vomiting, may be related to the higher incidence of postoperative nausea and vomiting. All right, so we've spent some time discussing the clinical problems and the effects that it can have. So let's change gears a little bit and talk about NIRS, or near infrared spectroscopy, and why it might be an important intervention to help address this problem and allow us to balance the necessary parts of beach chair surgery with the measurement of adequate cerebral perfusion. So first, it's important to talk about why routine vital signs have shortcomings and why they might not be enough to provide the necessary information that you need. So first, let's address pulse oximetry. Pulse oximetry is really a surrogate measure of oxygen supply. It really doesn't give us any indication whatsoever if the delivery of oxygen to tissues is adequate. It doesn't give us any information at all about oxygen balance. It's really a measure of systemic oxygen availability, or how much oxygen is contained in the blood. It doesn't give us any information about regional supply or demand, which makes it a limited value for addressing single organ oxygen supply and demand. Second, blood pressure. In beach chair surgery, there's certainly different ways of measuring blood pressure, either through a non-invasive cuff or through an arterial line, but either way, there are limitations to the monitoring of blood pressure. Non-invasive blood pressure must be adjusted for the hydrostatic gradient. It can be inaccurate depending on the cuff location, as we've seen. The size of the cuff makes a difference. For an arterial line, the location of the pressure transducer makes a difference. Typically, we place the pressure transducer at the level of the tragus of the ear to estimate brain pressure at that level. Also, when you talk about non-invasive blood pressure cuffs, the inflation frequency may also have to be adjusted for to counteract the effect of non-invasive blood pressure on IV flow. When it comes right down to it, non-invasive blood pressure is also really a surrogate measure. It's a surrogate measure of cardiac output and flow, but it can be misleading under various clinical conditions. So here's an interesting study looking at the relationship between non-invasive blood pressure and cerebral perfusion pressure. This study looked at 57 patients undergoing elective shoulder surgery in the beach chair position and measured mean arterial blood pressure, cerebral saturation using NIRS, and calculated the estimated mean arterial pressure at the level of the temporal lobe of the brain, or the ET map. There was a high incidence of cerebral desaturation. It had really no significant association whatsoever with the ET map. And this study showed that non-invasive blood pressure, even with appropriate adjustment, may not be that reliable for predicting cerebral perfusion. Now that we've talked a little bit about the limitations of non-invasive typical vital signs, let's talk a little bit about NIRS technology, how it works and how it fills in the gaps with these existing vital sign monitors. What's unique about NIRS cerebral oximetry is that it measures organ-specific extraction as well as utilization in real time. This is information that was only previously available through invasive means. The vascular bed of the microcirculation of the brain, we know, is made up about 25% arterial blood and 75% venous blood. So it demonstrates a mixed venous measure of oxygen supply and demand. Given this unique information, it can alert clinicians to ischemic threats in the cerebral and peripheral circulatory systems so that they can intervene earlier. Here's a schematic of how a cerebral oximeter probe works. It's made up of a sensor with a light source and two different detectors that penetrate through the skull. It measures a very small sample of tissue underneath the sensor. The sensors are applied in the frontal lobe region, but it relies on the assumption that the sample area under the sensor in the sampling region is representative of global perfusion. It's important to keep in mind that this may not always be true. There's both a shallow pathway, which is a shorter distance from the light source, and a deep pathway that's a farther distance from the light source. The short pathway measures light penetration to the level of the scalp and skull. If you subtract the shallow detector information from the deep detector information, you're left with only the tissue of interest that penetrates 2.5 centimeters below the level of the probe. This gives you real-time venous reserve capacity for following tissue oxygen extraction in this specific region of tissue underneath the sensor. It's important to keep in mind that NIRS values measures hemoglobin saturation in the microcirculation. These are very small vessels that exist at the site of gas exchange with the tissue. It reveals oxygen balance, revealing the status of oxygen delivery as well as oxygen consumption at the target tissue of the bed. What's important about that is it can give you information before functional changes occur and long before systemic changes are apparent. Here's a slide that talks about how RSO2, or regional saturation, is derived and validated. In order to come up with a variable, because regional saturation can't be compared to an invasively obtained gold standard, a new variable was created called field saturation. And essentially what the field saturation is jugular venous saturation at 75%, with 25% arterial saturation contribution based upon what we know the content of the mix of blood and the brain capillaries are. So if you look at this graph that compares here jugular venous saturation to regional saturation, if you look at 42 healthy subjects at various conditions of hypoxemia and hypercapnia, you can see that these values very closely approximate the center line, which tells you that these values are very well correlated. On the graph is a comparison of regional saturation to field saturation, and these also correlate very well between the regional saturation and field saturation. Because of this correlation, we know that we're acutely sensitive to changes in tissue oxygen supply and demand. So then on this slide, if you take the information obtained from collecting the information from those healthy subjects, you can see that jugular venous saturation and regional saturation both have very wide static normative ranges, which supports the idea that each variable is reflecting a very similar physiologic variable, which is an indication of cerebral oxygen balance. The first curve here in the orange bars shows a normal distribution of jugular bulb saturations in these healthy young volunteers. Next to that is the RSO2 curve in blue bars that shows intuitively a correlation with jugular venous bulb with a similar slope, but it's shifted to the right due to the additional arterial component of the measurement, as we would expect. These measures show that there's an average for cerebral oximetry of between about 60 and 80 is the normal range. And you can see here that jugular venous sat compared to regional sat differs by about 5%. In addition, we know that cerebral saturation can be measured bihemispherically, and we do know that there is some hemispheric asymmetry. And this is also true for jugular venous saturation values, as approximately greater than 10% asymmetry has been observed in test subjects about 66% of the time. Besides detection of critical events, NIRS is also used primarily in cardiac and vascular surgical procedures, usually to tailor therapy directed to the balance of oxygen to the brain. Interventions during these procedures are both similar and are aimed at restoring supply and demand imbalances to the brain through a series really of stepwise interventions that are often not mutually exclusive. In fact, it usually takes more than one intervention when a patient has experienced a clinical desaturation event. Majority of the time it requires multiple interventions to reverse this. However, most of the interventions that are in this algorithm primarily focus on improving supply of oxygen to the brain in both of these scenarios. If you take all of these stepwise intervention steps, you can put together an intervention algorithm such as this, which has been established for cardiac surgery. And if you go stepwise through this picture, you can see that the interventions involve things like improving mean arterial pressure, improving systemic oxygen saturation, normalizing arterial CO2, improving hemoglobin, or improving cardiac function. These are all things that should improve a patient who suffered a cerebral desaturation event. There have been multiple studies demonstrating improvements in outcome. Most of these have been definitively demonstrated in cardiac surgery. Examples of studies that have shown intervention improvements include improvements in major organ morbidity and mortality, improvement in postoperative cognitive decline in patients undergoing procedures, a reduction in blood product use, or being able to indicate when blood product use is necessary, a decrease in mechanical ventilation duration in patients undergoing cardiac surgery, and a decline in patients suffering stroke. So we have a pretty good understanding of the impact of cerebral oximetry in cardiac surgery and vascular surgery, but what about shoulder surgery? Many people want to know, how common is cerebral desaturation in the beach chair position? And then what is the impact of cerebral desaturation on outcomes? And how does NIRS actually change patient management? And how will it influence care in these patients? So let's take a look at that. So let's switch gears again and talk about some practical applications as well as the clinical evidence for beach chair shoulder surgery patients. Specifically, let's talk about what the incidence of cerebral desaturation events are in patients undergoing beach chair position surgery. What's the incidence of negative outcomes? And is there an association between cerebral desaturation events and outcomes? There have been a lot of studies looking at the incidence of cerebral desaturation events. In this large review study, there were 17 studies that showed an incidence between 0 and 66% incidence of cerebral desaturation events. That's quite a wide variation, but this incidence is particularly striking when we're looking at studies comparing beach chair positioning to patients undergoing surgery in the lateral decubitus position. Here's another study. This one's from 2015, looking at cerebral saturation at various time periods throughout surgery to determine where the largest changes occurred. And as you can see from these bars here on the left side of the slide, the highest incidence or the highest changes in RSO2 occurred with the change in positioning. This is from baseline to beach chair position, and this one is from beach chair position, once in beach chair position before incision. In this study, there was 76% incidence of a clinical desaturation event with a 25% drop in mean maximal RSO2. Here's an individual case that shows you what cerebral desaturation actually looks like in a particular patient. This is an example of a 56-year-old male with hypertension, obstructive sleep apnea, who's undergoing a rotator cuff repair. This graph demonstrates here the RSO2 value versus time, and it looks at both the left and the right cerebral oximetry sensors. You can see here at the beginning at baseline at 11:15, the saturation starts out in the normal range at about 75 bilaterally, and then shows exactly what happens when this patient was sat up into the beach chair position. You can see a profound bilateral decline that's pretty significant in cerebral saturation. And this occurs despite what most would consider really a reasonable mean arterial blood pressure of 76 millimeters of mercury. The patient then receives some treatment with medication to increase cardiac output and cerebral blood flow, and you can see the cerebral saturations return toward baseline. Earlier, I mentioned the impact of beach chair position on autoregulation. I told you we would talk about it. Well, here's a study that really tells us that the cerebral autoregulation that's taught during medical training classically demonstrates that it's preserved when a mean blood pressure is between 50 and 150 millimeters of mercury. However, various factors, including position, affect that range. In this study, the lower limit of autoregulation was actually much higher than once thought, particularly in beach chair position. In this study, they looked at 218 patients undergoing shoulder surgery in the beach chair position. They measured cerebral blood flow autoregulation as well as neurocognitive outcome and also various serum markers of neuronal injury. What they found was that autoregulation is diminished in patients who are positioned in the beach chair position. The regional saturation and the mean arterial pressure at the level of the brain were lower in beach chair position. They did not, however, find any differences in cognitive outcome or neuronal injury biomarkers in this particular study. Here's the results of their study. You can see here there's two different groups, 109 in the beach chair position and 109 in the lateral decubitus position. So compared to patients in the lateral decubitus position, beach chair position patients had a higher mean arterial pressure and had diminished autoregulation and a lower RSO2 and a lower mean arterial pressure. Although there was no difference in composite outcome, this study is significant since it demonstrates the challenges that clinicians have to face in this patient population. Here you can see that the mean arterial pressure at the lower limit of autoregulation was predicted to be higher in beach chair position patients. Besides revealing hidden threats to perfusion, cerebral oximetry can also detect critical events. For example, a unilateral decrease in cerebral saturation can be a sign of an ischemic event if the affected site is the tissue under the sensor. And here you can see what a unilateral decrease in cerebral saturation looks like. In this case, a 14% drop in the left-sided regional cerebral oxygenation that lasted for about 2 minutes was associated with weakness, drooping, and speech issues observed 3 hours after surgery in this patient. What about more subtle signs of neurologic injury? Does cerebral desaturation during beach chair position result in neurologic injury that can be detected with more subtle neurologic testing? Well, in this study, which was a prospective study of 28 patients undergoing surgery in the beach chair position, they measured intraoperative regional saturation, neurocognitive function outcomes, and again, biomarkers of neuronal injury. What they found is that 50% of patients in this study experienced a significant cerebral desaturation. Of those who had major desaturation, there was a correlation with changes in injury biomarkers. Changes in this biomarker was also associated with decreases in cognitive functioning in these patients. Here's the results of the study. First, they had a very high incidence of cerebral desaturation with positioning, and 50% with severe desaturation in this study. And what they showed was that neuroprotein biomarkers, NFL and tau, here shown in blue and gray, showed significant correlation with those who had more severe desaturation. And then here's another interesting study that measured several factors in patients undergoing beach chair position with controlled hypotension. 25% of patients in this study experienced a desaturation event at the time of beach chair positioning that correlated with reduced cerebral blood flow velocity in the middle cerebral artery measured by Doppler flow. Then on follow-up testing, those experiencing a clinical desaturation event scored worse on neurobehavioral testing 1 day after surgery. So based on some of this evidence, what are the clinical recommendations for reducing the risk of cerebral desaturation? And then what can we do if desaturation occurs? Well, here's some of the recommendations for mitigating cerebral desaturation risk. First, identify patients who are at high risk of cerebral desaturation events, particularly those with baseline hypertension who may need a higher mean arterial blood pressure for adequate cerebral perfusion. Make a plan with the surgical team for blood pressure management and what's the intervention threshold and what level of hypotension that should be allowed. Use things like leg elevation and compression stockings to prevent venous pooling that would lead to decreased cardiac output and decreased cerebral perfusion. Gradually put the patient into beach chair position to allow time for adequate compensation, and use the lowest possible angle that you can to put those patients into beach chair positioning. When a cerebral desaturation event is detected, first, if it's unilateral, check head positioning for vascular obstruction. First measurement should always be to increase blood pressure using a mean adjusted for position and blood pressure cuff location. Next, increase oxygen to 100%. Allow permissive hypercapnia to allow cerebral vasodilation. Decrease the beach chair angle if possible. Lastly, things like transfusion and decreasing oxygen demand through cooling or increased anesthetic depth can also be used in certain cases. Finally, here's an interesting study that talks about the effect of ventilation strategy or anesthetic agent on the effect of regional saturation in beach chair position. I think this study elegantly demonstrates the impact that these physiological variables can have. What I'll show you is that in this prospective randomized trial with 56 patients, they either received inhaled anesthetic agents or total IV anesthesia, and then had both FiO2, or fraction inspired of oxygen, and minute ventilation sequentially adjusted in these patients. What they found was that regional saturation declined significantly when these patients were placed in beach chair position. Raising the FiO2 to 100% oxygen and letting permissive hypercapnia with the end tidal CO2 to 45 reversed desaturation in these patients. They did not, however, find any effect of the anesthetic type. Here's what their results look like. On the left side is regional saturation, and then along the bottom are the stepwise interventions that were performed in this procedure. First, patients started out with a fraction of inspired oxygen of 30% and a normal end tidal CO2. Then, patients were placed into the beach chair position. You can see a significant decline in regional saturation in patients that were placed in the beach chair position in both patients who were receiving propofol or the inhaled anesthetic agent desflurane. Then the investigators increased the fraction of inspired oxygen up to 100% but left ventilation alone, and you can see that this somewhat attenuated the decline in cerebral desaturation. Then they not only increased the fraction of inspired oxygen to 100%, but also allowed the end-tidal CO2 to go up to 45 millimeters of mercury. So this hypercarbia and hyperoxia completely attenuated the decline in cerebral oxygen. And then finally, they put them back to an FiO2 of 30% and an end-tidal CO2 of 30 to bring these patients back to their baseline. I think this study elegantly shows that moderate hypercarbia as well as normal baric hyperoxia can attenuate desaturation seen in beach chair position regardless of the anesthetic type that the patients are undergoing. So let's summarize some of the evidence about patients in beach chair position. First, we know that cerebral desaturations occur frequently in the beach chair position. The beach chair position is associated with more cerebral desaturations than the lateral decubitus position. It's associated with diminished autoregulation and lower mean arterial pressure at the brain. Beach chair position has a much higher incidence of rare, devastating neurologic complications than the lateral decubitus position. And NIRS monitoring of cerebral desaturation can detect clinical cerebral desaturation events and guide patient management. And then finally, to summarize what we've talked about and what we've learned today, we do know that there's a rare but devastating hypoperfusion related event incidents that can occur in beach chair surgery positioning patients. Blood pressure, we know, is not an adequate surrogate for cerebral perfusion. The literature suggests that cerebral desaturation may be common in the beach chair position, and NIRS measuring cerebral oximetry can fill an unmet need in providing a fuller picture of blood pressure management with cerebral perfusion in mind. I want to thank you for your time and attention today, and I look forward to taking your questions and interacting with you in the next part of the program.
Thank you, Dr. Green, for taking the time to share your expertise and insights. We will now address questions that were submitted during the presentation. At this time, we are only able to address questions that were submitted in English. Additional questions and responses may not be relevant in all countries. So, Dr. Green, we have a few questions here for you. The first one is in-VOS monitoring part of shoulder surgery clinical practice guidelines?
Thank you for the question. I'm not aware of any published guidelines that recommend or require cerebral oximetry monitoring. It is certainly becoming much more common. I think there is a great deal of regional variation in practice, mostly driven by safety events. So what is typical is that in some organizations, if they've had a bad neurologic outcome related to this, cerebral oximetry monitoring becomes very attractive. In addition, I think you see cerebral oximetry monitoring for these patients in places that are very familiar with the technology and use it in other areas where it's much more common, such as cardiac surgery or vascular surgery.
Thank you, Dr. Green. Another question, at what percentage of RSO2 drop will you start to intervene?
So there are various thresholds that have been identified that signify risk to the patient. In my practice, cerebral oximetry is useful for not just intervening in a critical situation, but also for fine-tuning and tailoring the anesthetic. So typically I'll intervene when the cerebral oximetry drop is not extreme. So
any change, you can start with interventions along the intervention algorithm to correct even a small drop. What we do know from published clinical evidence and papers is that a change of more than 20% from baseline is associated with outcome issues. More importantly, though, it's not just the percentage drop, but the depth as well as the time spent below that level that's associated with poor outcomes. It's really the area under the curve. So a very short drop is not as bad as a drop that is maybe not as severe but persists for a long period of time. And then we know certainly there are some patients that even despite extreme drop, even if you proceed with interventions, it's very rare, but there are some patients who you cannot really get them back to their baseline saturation. In that case, we try all the interventions we can to try to get them to the best cerebral saturation that we can.
Were there instances where they had to remove the patient from the beach chair position because the RSO2 was not really going back to baseline?
Certainly that can happen. Typically, multiple interventions, along with sometimes just changing the beach chair angle, can make a significant difference. So it isn't necessarily changing the position entirely, but reduction in the extreme of position can really make a difference. And then multiple interventions, as we discussed, to do everything we can to manipulate the perfusion to the brain.
Dr. Green, there are no more questions in the Q&A box. So thank you very much for sharing your knowledge, your expertise with everyone on this webcast. I think everybody learned a lot today, especially about in-bus monitoring and beach chair position.
Thank you. I was pleased to be here with you today and appreciate the time and attention to this topic.
Thank you, everyone. Before we end, we would also appreciate your feedback by answering the 5-question survey, which will appear at the close of this broadcast. It should take no longer than 2 to 3 minutes to complete. So thank you once again for your time and attention. See you soon.